Welcome to Let's Talk. My name is Abhi Chakrabarti, and we are here to discuss hard topics with smart people, and in this case, with my friend Manuel Bardiz, discussing the relevance of traceability for dosimetry. Hi, Manuel. Welcome.
Hi, Abby.
Who are you? What is it that you do?
Well, I'm a medical physicist and I work for the French National Institute of Health and Medical Research. So I'm a research scientist and I've been doing radiopharmaceutical dosimetry for more than 35 years. So basically, I'm still doing my master research project on that topic.
I see. So tell me, what is it? What's keeping you busy these days? What is your immediate area of interest?
At the moment, I think that the era of the pioneers, let's say that like that, the very beginning of that field, very exciting, that is clinical dosimetry is gone. But so dosimetry is spreading, it's disseminated in more and more countries. And the most important thing, in my opinion, is to make sure that dosimetry is done in the same way in different places. And therefore, there is a growing need for traceability, making sure that we're able to reproduce what we're doing from one place to another, or also in time. When you've been in the field for a while, so you've seen a lot, the hype curve. So there was in the 1990s with radioimmunotherapy. I mean, that was going to cure all the cancers. And then we were strongly believing that dosimetry would help personalize the treatments. And then the hype went down, and then it goes up again. We have a peptide receptor radionuclide therapy. Now we have PSMA. So we have more and more fascinating drugs. But the thing is that at the moment, they are delivered mostly, as you know, using a sort of one-size-fits-all paradigm. So dosimetry is designed to help personalize the treatment. How to do it in practice and how fast is it spreading? Well, at the moment, it really depends on the resources that are available locally in the different hospital. There's a huge variability from one place to another one. And also the desire, the wish of the medical doctor and to implement clinical dosimetry in clinical practice. But most of all, I think it's a decision of a whole department. I mean, you cannot do dosimetry if you don't have nurses, the technologies. Everyone has to, pull the thing in the same direction.
And are you seeing an increase in adoption? I mean, people willing, and are you involved in?
Yeah. There's certainly something going on, even though, again, it's not necessarily mandatory, depending on the country, that Europe has got different legislation as the US and so on. But still, there's a growing number of centers that are increasingly implementing clinical dosimetry. And by doing that, it's a sort of virtuous circle because they generate data, and that data proves that the interest, the added value of clinical dosimetry. And when that is proved and published, obviously it's a motivation to do further and to do more.
The research that you are doing on traceability, is that something that will be deployed clinically? What are you doing? What is the contribution of your research to clinical utilization, let's say?
A lot of people are talking about standardization in the sense of within a clinical trial, we want all the images to be acquired exactly in the same way. Then if we try to transpose that in a clinical situation, the thing is that not all hospitals have got the same resources. Not all hospitals have got the same experience. So it's fairly understandable that different hospitals behave differently in terms of clinical dosimetry implementation. Therefore, what I'm aiming for is to make sure that we can transpose the results obtained in one center to another center, one center with a given methodology, with the resources that are locally present, to another one with a different methodology, etc., etc. So it's not about something absolutely uniform everywhere, because that would mean everyone has got the same resources, and that is not the case. So what is very needed is making sure that we know exactly what's being done so we can transpose the results and understand the results from one team, one center to another one. And like that, we have a possibility to disseminate the treatment in a growing number of places. And that means more patients that can benefit from basically an equivalent standard of care and the same type of optimized treatment everywhere.
So if I were to understand you, what you are doing through traceability of the symmetry is almost just like democratizing quality, let's say. It is not in the preserve of those that are fully resourced, but everyone, let's say.
And that goes through implementing, as you mentioned, quality assurance. And quality assurance is something that is absolutely well known, for example, in external beam radiotherapy. Also, all physicist colleagues in external beam radiotherapy, I've got a daily experience of implementing quality assurance. As I mentioned, for nuclear medicine therapy, the era of the pioneers is gone. So now we're becoming mainstream. So we're implementing dosimetry in a growing number of centers. So we do need to implement quality assurance in that field. And that, yes, is making sure that standard level of care, democratized for a growing number of people and centers, not only in one country, but in many countries.
And then beyond your immediate area of research, so I guess the work you're doing, you would publish, you're also teaching. What are the things you're doing to spread the word?
Well, we have to. It's a niche. It's a very small world, right? So when I started mine, people will not understand that it was before the internet era, right? So being a PhD student in that time, so before the year, in 1990, you had the feeling that you were alone in a very small island and completely isolated, right? So that possibly is a reason why I try to develop networks, put people together, communicate with different colleagues. So we started in the early 2000 I participated to the creation of the dosimetry committee within the European Association of Nuclear Medicine. And that was already networking. So putting together experts from different countries, and we were doing research project, dissemination, teaching, lecturing a lot of students to make sure that we have more colleagues. More recently now, I'm working within the European Federation of Organization for Medical Physics. We have a special interest group, which is a network of professionals. And there's about more than 200 of us, 210, like last time I counted, of colleagues involved in nuclear medicine dosimetry at different level. And it's fine. Everyone is trying to work out together how to advance the field. So, and that goes with lecturing, education, that goes with dissemination of resources. So we are disseminating free resources to help people to perform dosimetry. We have case reports. So people are reporting on their practice of dosimetry, and then between colleagues, we are discussing that in a very nice way. So it's not like in a congress where you really want to show off, and you have to demonstrate how good you are, right? So within the network, it's about everybody listen to everyone and try to understand and try to improve everybody's practice. So yeah, the networking is so important in a world that we do not have that many colleagues working in clinical dosimetry. So we have to make sure that we communicate.
And I know your involvement is at the European level, but beyond the European shores, are you also communicating or talking with other countries and regions?
So there are two ways. One is that EFOMP, and I think it's a unique situation, actually allows members, like individual associate members, to register as individuals. So I'm very glad to report that in our group, we have colleagues from India, from Saudi, from different parts of the world, and they can work as EFOMP members, even though they're not European. But then, and this is I'm starting my second and last term as a chairman of the Siegfried, and that 3-year term will be dedicated in establishing, developing, increasing relationship with different international bodies. So that's also one of the reasons why I'm here today in the SNMMI, because we really want to increase communication and collaboration with SNMMI, with the American Association of Medical Physicists, the AAPM, and obviously the European Association of Nuclear Medicine, and possibly Asian, Middle East, and so on. We really want to increase communication between different regions, not just stay at the European level.
in the end, this is about giving treatment. It's about supporting treatments, right? So physicists doing their stuff is one thing, but how receptive are physicians to your efforts?
Okay, let's say that the only difference between a physician who is against dosimetry and a physician who is for dosimetry, and if he has a physicist to do it. Right? So whenever a physician has got a physicist to do dosimetry, he usually very fast turn into a dosimetry believer. So that's how you make a field evolve. You have to train a lot of people, make sure that it's available, that it's that the tools are fast, that it's not a burden for the nuclear medicine department, because that matters. So it's doable. It has to be doable in a clinical environment. That is just increasingly possible. So, and that changes the game. Also, as we know, it's not a matter of public practice or private practice and whatever, but it's very hard for a hospital or for a nuclear medicine department. If a neighbor is doing it, then they have to, sooner or late, they have to. So that dissemination is growing by, some centers are doing it, and then another one, and then another one, and that's how it progresses.
And to what extent is the dialogue extending beyond specialists to the patient? How aware are the patients of what they can receive?
And it's a wonderful question, because we are dealing with ionizing radiation. So there is not necessarily a high level of education of the patient on ionizing radiation, even though all of us, the public has known about, he's got something, he's been treated with radiation, right? That all radiation is a little special because you inject radiation in people, and sometimes that may cause, problems in the sense people are just scared. So it means that we have a role. We really need to inform the patient with concept, words, vocabulary that they can understand, so they know exactly what we're doing. And I must proudly say that in nuclear medicine, we're actually aiming at having much, much less side effect than in other type of treatment with ionizing radiation. So I think we can be very proud of what we're doing in nuclear medicine, because we're actually treating with radiation, fair enough, but we have if you compare even with non-ionizing radiation therapies like chemotherapy, very often the kind of treatment that we are delivering has much less side effect than other non-radioactive treatments. So we need to discuss with patients, we need to explain, we need to be clear, very clear, and everybody has to do it. It's not just a physicist who's normally the expert in radiation safety, but it's the MD, it's all the nurses, technologists. Everybody needs to have the information and be able to transfer the information.
And tell me, to what extent, so far we've been talking nuclear medicine, but how closely do you work with radiation oncology or possibly medical oncology? What is that communication like?
Let's say it's viable, and let's say it's vital. It's also amazingly varying from one country to the next. As you know, nuclear medicine as a specialty, depending on the country, is attached to radiology and so on. And some countries, the treatment, are only delivered under the responsibility of a nuclear medicine physicians. In Scandinavia, it's a responsibility of a medical oncologist. And so the nuclear medicine physician is doing his share. Physicist is also responsible of radiation calculation, absorbed calculation, and so on. So it's highly variable. But obviously, as I said initially, it's a decision of the nuclear medicine department as a whole. But you're absolutely right. It's not just the nuclear medicine department. It's a medical decision that associates different professional, healthcare professional, and that's radiation oncologists, and so on. Because basically, these are the ones who are actually treating and following the patient.
Right. But are you seeing success in this collaboration?
Let's put it the other way around. It cannot be successful if you don't have that. So in all the centers that I know of that are successfully delivering the treatment and that are advancing the treatment, that are making progress, publication, and treating better patients, achieving results, systematically is when you have a very good communication between different professionals. There is no such way of, an isolated professional was able to do everything by himself. It's not possible. Just not possible,
Yeah.
not happening.
And just going back to traceability, what we began, how is that going? This is your work today. You want to see traceability, reproducibility, right? Well, how are you doing? How much, what mark would you give yourself out of 10 as to the current state, and what are you hoping for?
Well, the state, and I'm not obviously not saying about me, but the thing is, we do what we have to do is first observe the practice, the professional practice in different centers worldwide. So we need to have a snapshot of what is currently being done in terms of clinical dosimetry. Not everybody is doing clinical dosimetry in the same way with the same tool. So my current job is to try with a group of friends and colleagues to make sure that I have all the list of all the procedures that are being used in the different centers worldwide. Then we're going to extract all the parameters that we need to store, write down to ensure traceability and reproducibility. For example, the administered activity, that's an easy one, but also the way you acquire the images, the way you process the images, the way you delineate tumors on the images, the way you compute absorb those, obviously. And all that has to be recorded in a standardized way. So that's why we're thinking a lot about a specific standard for nuclear medicine dosimetry in therapy. And then that being done, we have to sort of make sure that we have a full wish list of what we want to see in the future implemented. And then we have to discuss with manufacturer, people who are developing software and so on, just to make sure that they are aware of that crucial need so they can implement that in their own solution or in their own software. So that's, it's sort of long-term objective that I'm very glad to report that it started recently, and there's a lot of people interested, including companies who are interested in, because they see the need of standardization, they see the need of traceability.
Right. Do you have any near-term sort of milestones? This is quite a big project. Standardization is not easy. What would be quick successes that you see?
So what we are focusing on at the moment is traceability. The standardization is much broader, so it's not going to, it's going to take more time. But for traceability, we just have established an international group of people willing to work on the topic, and the deadline is 2 years.
Right.
So within the 2 years, we want to have the 4 tasks that I mentioned. So namely, identifying the different clinical dosimetry workflow that are being implemented worldwide. Second, the list of the variable that need to be stored. Third step I haven't mentioned is looking around in the different standards, including DICOM standard, what's already available and what is missing, so that eventually we can turn in the direction of a DICOM committee and say, look, this is what we need, and this is a list of the things that we'd like to see in a new standard. So, and that objective, at least to a proposal to a DICOM committee, we set 2 years.
Of course, as you are, clearly between now and then these 2 years, clinical dosimetry is happening. People are getting treated, and records are being kept. How are you spreading this message? You don't have to wait for 2 years to decide what, right?
No.
Even tomorrow, a patient's getting treated, dosimetry getting done.
I'm personally doing a lot of lecturing. So I'm lecturing not only at the national level, but also in different international institutions. So I'm teaching. I'm trying to focus on practical lecturing, practical education on how to do clinical dosimetry in real life to my young colleagues. So that is one thing, because that allows to raise the standard. Then also there are some, let's say, common sense things that are passing, like if you're lucky enough and have 2 physicists able to process clinical dosimetry, you have 2 ways of doing that. You just separate the patient in 2 halves, and everybody is doing 1 half of the patient. The other way, which I believe is much more robust, is to say, I'm doing the dosimetry, but you're going to check my results.
Right.
And then tomorrow we change. And that has many, many beneficial consequences. One is that if I know that someone is going to check what I'm doing, I have to be very, very careful in what I'm doing. And we've seen the improvement of the quality. The fact that we're not alone is also very important. I mean, I can be the smartest guy on earth. If I'm on my own, I will make mistakes. And if no one is checking and no one is pointing out the mistakes I've made, this mistake will stay. So I think that is typically the kind of thing that we push a lot. Like, let's do a sort of network, let's do teamwork. Even if we don't belong to the same hospital, it doesn't really matter. Let's talk about exchanging the way we're doing things. That's how we are progressing. And that is happening now. So we have been doing, I mean, within the Siegfried, the network that I mentioned already, the case report thing is very important. I mean, everyone, I mean, you are going to present a patient and the way you do the processing, and we are going to discuss together how to improve that. And then we change. Somebody else will do it. I mean, that's how you change a game slowly, but continuously.
If you could have one or two words of either advice or recommendation, what would the takeaway be from listening to this conversation?
My whole career is not finished, but it's a big part of it. Communicate, talk to people, exchange with people. I mean, don't stay on your own, because if you stay on your own, you're not progressing. If you stay on your own, you make mistakes. So that's the only message that I really want to stress and put forward is that exchange, communicate. You're not alone. You're never alone. Please work with your peers.
That was a good conversation. Thank you, Manuel. Let's talk again.